So, thank you, Madeline. So today we're going to be talking about taking a sexual history. And I know you guys know how to do this, but one of the trickier things, or not tricky, but one of the things that we often get feedback about just in general for people that are trying to think about prep, even for like younger populations, young adults and younger, is um, this idea of, how to get at some of these nuances and how to really uh, identify young people who could best benefit from prep. And Dr. Alope or Letitia, she's going to go over prep more in detail. Um, but we're going to talk about some of the nuances that may be able to help you kind of, be a little bit more effective, particularly when you have someone that you're like, I really need to find a way to convince him or her to be on prep in the next visit or a couple visits. And so my background, I'm an adolescent medicine physician. Again, I was at UAB and I'm currently at Emory. And I do the gamut of everything, but was probably the only person doing prep in teenagers for many years in Alabama. And so we're going to just go through this. Yeah. And I'm going to try to make it interactive because I know I can be wordy and it can be a lot of slides. So stop me with questions, comments, or experiences, please. So our objectives are really to understand sexual behaviors, STIs, and HIV epidemiology for young people in Alabama, as well as to learn, refresh, refine our ability to initiate and complete comprehensive, time-efficient, age-appropriate sexual history taking with the same population, and use a strengths-based approach really to help with that and center youth in their own care. And so this is the outline. So just pay attention to the number of colors. There are 6 different colors of the slides. And I want to give kudos to Madeline because she is our graphic extraordinaire with slides. And so I love this slide because again, a lot of times when we think about taking a sexual history, let alone and maybe someone that's young and may not know what sex is and all these other things, it really does feel like if we ask the question of like, have you ever had sex? Are you having sex? We're opening a can of worms and it might derail our entire visit. And so this slide really kind of hopefully makes you feel like you're at home because these are some of the common things we hear from all types of providers, at least in this country, as far as why or why not they may be excited to talk about sex with teens. And obviously there are legal and ethical issues, which will go through some consent and confidentiality things. Comfort and confidence. Some people are comfortable and confident. Some are one or the other. Obviously, there's differences in demographics. So whether that's age, gender, ethnicity, cultural values, things like that. Most of the time, there are young people that do come in and ask for STI testing, but a lot of times we're seeing them and maybe it's a well child visit or a well person visit, or they're coming in with some kind of complaint and sex is just something, if we open it up, we're going to get completely derailed, like I said. There are some of us that don't like adolescents. I'm clearly not that person since that's my subspecialty. And I know you guys do family medicine, so you guys might you might like the younger age or the older age. So that could be you, or it might not be you. Making sure that we're thinking about how to do this in a developmentally appropriate manner and understanding the difference between actual age and whether that is congruent with their, behavioral developmental age can be a challenge, even with the topic of sex. There's a complexity of sexual issues and, even the idea of, you may be talking about sex and at some point realize the person's recounting a non-consensual sexual activity as opposed to like consensual sex, and that just derails the whole visit, as we all know. If you've got parents and or someone else in the room, how do we get around that? And then, what happens when we have different values, cultural, religious, familial values about sex, as well as sex in teenagers, and how do we kind of navigate that while we're in our physician roles, because we all wear multiple hats and are multiple people with multiple identities. And then concern about availability of resources, because all of us know we get that 15-minute visit and a teen is never 15 minutes. So sexual health epidemiology in Alabama adolescents. Hopefully everybody's familiar with the CDC's Youth Risk Behavior Surveillance Survey. If you've never looked at it, please look at it. It has stuff about sex, obviously, because we're talking about sex, but it has, diet, exercise, substance use, all kinds of things. So take a look at it. Alabama did have data for 2019 as far as looking at high school students in the state and looking at sexual activity. And so you can see that in Alabama, among our high school students, Almost about 40% are currently sexually active within the last few months. Of that, almost half of them did not use a condom during their last encounter. And then we have low rates of both STI as well as HIV testing in our state compared to what it should be. We're right along the lines of not awesome, but most of the country, just to make you feel better, is in that same category. As far as STIs in general, unfortunately, our youth, usually between 13 to 24, 13 to 29, depending on what you look at, account for the majority of STIs. So you can see here, starting with the figure on the left, you've got the age distribution of things like chlamydia. And so you can see that among 15 to 19 and 20 to 24-year-olds, they account for 28 and 37% respectively of chlamydia infections. Gonorrhea looks very similar with that age group. Again, that age group is accounting for more than half. And then syphilis, thankfully, it's a smaller percentage and mostly in older adolescents or young adults. But again, almost a quarter of syphilis infections are among young people. When we look at HIV, we see disparities as well. Madeline, myself, and a lot of our team, we got started doing this specifically looking at HIV in Black young women, people. And so that's where this slide comes from. But you can even look for males on the left. If you're comparing Black males to white males or Latino males to white males, you can still see that there's at least 2 to 1 as far as Latino, and almost 5 and some change to 1 for Black males compared to white males as far as HIV diagnoses. And then the rates are even more unfortunate when you look at women or females. Hispanic and Latino females are almost 4 to 1 compared to white females, and then Black females are about 10 to 1. Which is what that is. Okay. All right. And then this is still looking at HIV because we know this whole workshop is about, these 2 workshops are about PrEP and HIV prevention. And so when you look at rates of HIV, you can see here, if you look at the races, you've got Black, white, multiracial, Hispanic, other, or unknown. And then you do have the different genders and then all the genders combined. We know that Black males have the highest rate of new HIV infections. And that's consistent not only among all the males, but in all the groups. And then, unfortunately, it's the same for Black women as well. But you can kind of see it goes Black women, then multiracial, Hispanic, and then white and other. Okay. So now we're going to talk about adolescent development. It's just always, we know we're all trained in this, but it's always important for us to bring our minds back to, the fact that there are different stages of adolescence. And so depending on the citation you're looking at, it could be anywhere from 10 to 24, 10 to 25, 11 to 25. But it's this idea of taking a young person and going from childhood to adulthood. And we know classically adulthood is defined as the completion of the development of the frontal cortex. And so that's why it goes so far into what we consider adulthood or young adulthood. There are physical, emotional, intellectual changes. There are social changes. And, we are all integral in helping them go through those stages of change and development and reaching them where they are. In addition, things that we want to think about are their developmental tasks. We really want to help make them understand and know how to form caring and supportive relationships, whether they're peers, their friends, their romantic interests, or even understanding how to do that with their family. We want them to have a positive role and a positive self vision of themselves and their community, as well as engage in wellness-oriented and healthy behaviors. That's those 3 right there, like really the sum of when you think of adolescence. But we know, again, we want to make sure that they are hopefully reaching whatever their physical, cognitive, emotional, social, and moral optimal persons are. And sometimes they do that on their own with our help, without our help, and other times we have to really help them do one or more parts of that. Resiliency is a key factor, and we're not going to go into it, I think, in this talk, but really understanding that resiliency is a great factor in helping prevent HIV in our young people. We also want them to become autonomous and be and display autonomy and really make sure that they know how to do things and feel comfortable and confident as they can, doing it on their own, and inspire hopefulness. So here are the stages of adolescence. And so you can see this is the first stage of the early adolescence, the ones that we probably think about the most and maybe the least comfortable talking about sex with, which are our 10 to 14-year-olds. They're getting taller, they're starting to smell, body parts are growing and things like of that nature. But they're still pretty concrete, right? These are the kids that we don't say, don't smoke because you get cancer. We say, don't smoke because your breath will smell and someone's gonna tell you that your breath smells, right? Um, and then you can see emotionally, they're all over the map, right? And they just really want to fit in and kind of start to kind of get away from their parents and develop their own kind of identity. And that's what they think, but they're really developing their pure identity. Middle adolescents are probably the adolescents we might be most comfortable with. Um, and so they're from 15 to 17 generally. They're almost completing puberty, or they might have already completed puberty, depending on the gender and the family history. They are a little less concrete and can actually do more as far as thinking through their emotions and the consequences. And hopefully they've started to really kind of identify a little bit more about who they are, what they want. They're thinking about romantic relationships, although they're still really influenced by their peers in that manner. And that's kind of where we see them get into a little bit of a challenge sometimes with these relationships. But they're developing who they are, and they're starting to really gain a sense of themselves separate from their family identity. And then finally, there's the late adolescents, which are those 18 to 24-year-olds. And they probably look like us. I'm making the assumption that might be wrong, but that we are all done with adolescence. And so they look like all of us on this talk. They can think abstractly for the most part, and are empathetic. They have a really strong sense of who they are. They're trying to figure out their larger purpose in society. And a lot of that moodiness we saw early on is finally starting to kind of mellow out. And for that reason, they want meaningful relationships, and they're actually able to maintain those a little bit better than their other two peer groups of adolescents. And so those are the stages. And it's important because when we get to it later on, we'll kind of see maybe how to adjust our questions depending on, what stage of adolescence someone is in, or what stage they're behaving like they're in, right? We all know those 19-year-olds that are really like 14 mentally. So questions about development, but I suspect not because you guys are all family med. So, okay. So we're going to talk about all the fun stuff that nobody wants to talk about. And so we'll start with the importance of confidential care. I like this survey. It's older, but I like it because it really asks the question of, if we require us as providers, or we're required to tell parents that the kids are having sex or that they're seeking out these sexual health services, will that stop kids from having sex? And the answer is no. We'll start with the beginning. So they looked at over 500 sexually active adolescents. So all these adolescents were having sex, and they asked that question, particularly pertaining to contraception. If your parent had to be notified that you were having contraception, would you stop using healthcare services? Over half would stop using all healthcare services. Notice how it says all and not just contraception. 11% would stop or delay HIV, STI testing or treatment. But the bottom line is that virtually none of them would stop having sex. So now we have a group of individuals that are still sexually active, but are not seeking care at all. And so it's really important that they have access to confidential services. And so the ways to kind of do that within our practices as best as we can. I know you guys are all individuals, except for maybe your program director that you're attending that's on here, Dr. Green, right? I think is who it is. The rest of you guys may have to kind of like advocate, but really having confidentiality letters to send to patients and parents, or maybe having a statement in your clinic room, posters and things in your clinic room. I know the clinic that I was in Birmingham, we had an adolescent young adult centered rights statement at one point, in-person discussions about confidentiality with patients, and then really thinking about your portal. I don't know, do you guys use Epic or not?
Athena.
Which one?
Athena.
Athena. Okay. With Athena, do you guys have a portal? I take it.
We do.
How does your portal work as far as like when you have a patient of a certain age and parent versus patient and who can see what?
I think the patients can make a portal account, but often the parents have access to it. The portal uptake in our clinic is very poor at baseline, so it only occasionally comes into play.
Okay, so that's, I laugh because when I moved here to Atlanta, like they're like everybody has to have a portal, and I was like, oh my gosh. But I laugh because that might be helpful for some of your teens. For some of your teens, it's probably neutral. But the idea of really knowing, what gets released into the portal, is the parent the primary owner, or it sounds like the teen can actually be the primary owner where you guys are, and how does the parent have access? Do they have proxy access? And those things are important. And a lot of the teens are kind of realizing that. And so I have some teens that are like, no, don't send anything to the portal. Just tell me or write it on a piece of paper. And I'll put it in my pocket maybe, or I'll put it in my phone, more so. Are there other things you guys do in your clinics that really remind the young person or the parents that you guys offer confidential services or have a confidential time? No?
Just reminding the patients that what they say to us is confidential, within the bounds of the law.
Perfect, perfect. Okay. Awesome.
I don't even know, it's possible that there are, I mean, I have no idea like what the setup actually is with the portal, and if there's certain things that get flagged as being, confidential. I guess one thing that I don't know, maybe it's on one of your later slides, but the one question that would always come up would be, how confidential is it really, especially with, reimbursement payers, and when that explanation of benefits pops up, where are you at then?
Yeah. That's a great question. So, when you get your services, how confidential is it? So there's two things to think about. Like, if you have like a public payer, so in this case it'd be Medicaid, Alabama Medicaid and Georgia Medicaid, actually. Neither one of them send home explanation of benefits. And I thought that was like an overworked thing, but apparently they follow national guidelines about privacy. But if you have individuals that have private insurance, so that's all your commercial insurances that you can think of, you're completely correct. The explanation of benefits might go home. And so I usually will approach that and say, your parents best. Are your do your well, you may not know if your parents read it, but do your parents read every single piece of mail? Because if so, they might end up reading their explanation of benefits and kind of seeing that you got these services. And if that's the case, if the patient's like, yeah, that's my parent, they read everything, then I'm like, well, how can we go ahead and prep you? This is option one. How can we go ahead and prep you? Because the question is going to come up like, hey, Billy, I see that you got a chlamydia test today or whatever day, like, why was that? Like, so I start the discussion with the teen. For the teens that are like, there's no way in the world I could ever possibly even say that I'm sexually active without like getting thrown out of my house or, something else happening. Before I do the rest of what I'm going to do as far as things that require a bill, I try to identify if there's a place close to them that may offer free confidential services that don't require billing. And we have a slide somewhere close to here on Title 10 clinics. And so there might be some, especially since you're in the metro area, there might be some close enough that the patient might be willing to get to. And so that's what I do. And it's always, if you can, it's great to get them ready. Because some teens are like, yeah, I really don't want to have that conversation, but if you can be with me, that'd be great. But other teens, I never doubt a teen when they're like, that's just not going to happen because I'm concerned of X, Y, and Z. So it's a tricky thing. And so that's completely correct. The other thing that some people also share when they're doing their confidentiality statement, like you did, Spencer, is they'll say, like there might be a situation where I'll discuss your case with another provider or other members of the team so that we can get you the help you need. Some teams even want to know that. I generally don't say that unless, as we're talking through the discussion, I'm like, so I need to share this with so and so to help you out. But that's something that other teams do pick up on. Okay. Good points. So this is actually what Spencer actually went through, which is like just a way to kind of share that the discussions are private. And so this, is like, hi, and this is my intro. Hi, I'm Dr. Hill. I use she, her pronouns. And I usually say, who's with you? I don't even guess anymore. I'm like, who's with you right there? Or are they in the waiting room and they tell me who it is? But everything that you share with me is confidential, which means I don't tell anybody unless, this is what I say, unless I feel like you or someone else is in danger or a danger to themselves. And then I even add the caveat, because I do see a lot of patients that have a lot of medical needs complicated by complex psycho or social needs. And I say, and sometimes there are going to be some things that, in order for you to get the best treatment you need, are going to be really complicated to get in the healthcare system. And so I might ask you how to involve so and so. So I give teens a heads up about that, because I see too many of them, and I'm like, there's no way you're going to manage this yourself. But anyway, information is not shared with other people unless we are concerned that someone's in danger. Is this one? So these are the minor consent laws in Alabama. How comfortable do you guys feel knowing these laws? And it's okay if you don't know them. It's fine to look them up. So in Alabama, in general, there's like a general medical care law. And so a lot of things individuals can consent to when they're 14 years of age. But when we're thinking about different types of services, contraceptive services in Alabama, once you're 14, or if you meet one of these criteria for, having graduated high school, been married, divorced, or a parent, you can consent to some of these things even younger than 14. For STI testing and HIV testing, in most places in the country, it's 12. That's probably the one thing that's almost uniform. And so Alabama is no exception. And then emergency contraception, there are no age restrictions. I will say Alabama, like many states in our union, does not have specific policies that require the emergency room to talk about emergency contraception with you if you come in and disclose, not necessarily an assault, because they usually discuss it with you then, but if you disclose that you had unprotected sex a couple days ago. There are a few states in the country that state that. And so I say that because a lot of young people don't know about emergency contraception. And then as far as prenatal care, childbirth, child's medical cares, and adoption services for the child you are pregnant with, there are no age restrictions for that. And obviously, we didn't update these, but with recent legislation, you cannot consent to an abortion. I'll make sure I say that. Try to make sure I'm covering everything. So with minor consent and confidentiality in Alabama, we have some questions to keep you hopefully engaged and awake. And so we have Brianna. She's our first young person. She's 15. She's requesting an IUD and does not have the consent of her parent. The physician determines that without the IUD, probable health hazards would occur, which probably most likely would be pregnancy with a increased likelihood of not great outcomes, because all of our teenagers have an increased risk compared to an adult of preterm delivery and all kinds of things. So what do you want to do? Do you tell the patient that she has to come back with parents' consent? Do you inform the patient that you can and will perform the procedure, but must call a parent to notify them? And do you explain to the patient that you can perform the procedure without parental consent, but if she pays with her parents' insurance, they may receive an explanation of benefits?
Yes, see.
Yeah, I think this is the one Dr. Green was hinting at a little earlier. C, yeah. And I will say there are a couple of states that are B. Alabama's not one of them, though. So you have to explain, you can explain to Brianna that you can do this, but that, her parents may receive that explanation of benefits. And so again, it's a great opportunity to talk to Brianna about, like, so in the event that your parent comes up to you and is like, what is this thing here? What do you want to tell them? Do you want me to go ahead and talk with you with them? How do you want to handle this? Then you've got Michael. Michael's 14 and he's requesting a chlamydia test. He doesn't want to tell his dad, who's in the waiting room. Does he need consent from his father to get a chlamydia test? I see a couple head shakes. I see 3 head shakes of no. Awesome. So minors in Alabama have the right to consent to STI testing and treatment without a parent's consent, and that goes down to age 12, actually. Then you've got Jade. I've messed up her name. You've got Jade. She's 16. Can she receive a pregnancy test and prenatal care without informing her parents? Oops, I gave you the answer because I clicked quickly, but yes. Yes, she can. Because she is able to consent to that at any age. Again, and that includes adoption. The only thing it doesn't include is if she would like to terminate her pregnancy. Then you have Carlos. Let me not click buttons this time. He's 15 and he needs mental health care. Which of these statements is true for him? He can consent to counseling without his parents' knowledge or consent. If he needs to, he can consent to depression medication without his parents' consent. If he needs to, he can get inpatient treatment without his parents' consent. Additionally, he needs to get his parents' consent for any sort of mental health treatment. And we didn't actually talk about mental health. So this is going to be a fun, what do you do? What have you experienced in life? And I'll defer to Dr. Green after, in case he wants to go after his lovely residents.
I'm guessing he needs his parents' consent for mental health treatment.
Okay.
I concur.
Okay. And Dr. Green, do you want to weigh in or you want to watch?
I'm honestly not sure. The situation doesn't ever really come up. I haven't seen it in clinic that we've had someone where a minor's needed mental health care and the parents, haven't been, entirely on board with them. So
That's good. That's a good thing. Because I have seen that last part where it's like, they're like, that doesn't exist or, but that's good.
I guess I have a question.
Yeah, go ahead.
No, I guess if it was like medication wise, then maybe I would be more inclined to getting the parents' consent. If it was just, has some mental health issues that wants to talk about to somebody, I would assume we can, help him out. And as long as he's not, suicidal or at risk of hurting himself or others, then we don't have to disclose that to the parents. That's, I guess, what my understanding of this was.
Yeah, and that's where it is. So he can consent to like outpatient mental health services without his parents' consent. The big one, and depending on in Alabama, that general medical treatment, if your program is aware of that and follows that, technically he could consent to medications, although the safe answer would be to obviously talk with his parents, make sure they both know what the medicines is. But the big no with this law is that they can't consent to any kind of inpatient treatment without a parent's consent for mental health. And so, if you're looking at, if they're actively trying to kill themselves, that's the whole thing. But like, if you're like, they need inpatient treatment at somebody's mental health facility for medication management, for stabilization, they have to have parents' consent for that. Counseling is an easy yes. Medications are kind of in the middle. Inpatient is an easy no. Does that help? I have another one. And a minor under the age of 14, which of the following requires parent or guardian consent? So this is someone that's less than 14 years of age. STI and STD testing, vaccinations, prescription contraception, mental health services. I know. Fun times. Are there any, you said contraception? Okay, Dr. Green is shaking his head no.
well, actually, no, there are some specific exemptions for vaccinations too.
Think about the vaccinations as pre-COVID, because I know what you're getting at. Think of vaccinations as pre-COVID epidemic.
I guess we're also assuming that this minor under the age of 14 has never been married, or is not married, divorced.
Correct. This is a non-emancipated minor. This is a regular garden variety minor.
Well, what have we already said? We said that contraception age in Alabama is 14 plus or emancipated. So if they're under the age of 14, then that should be the prescription contraceptives.
All right, let's go. And Spencer, you're just nodding on board. You're like, yep, all of the above. Okay. All right. C, good job. So minors need parent or guardian consent for prescription contraception unless, and we're going to talk about Title 10 clinics, unless they're covered by Medicaid or seeking care in a Title 10 clinic. And so we're going to talk about that. The vaccine one is tricky because I think there was a law passed within the last 3 years during the pandemic where you definitely have to get parent consent for the COVID vaccine, if I'm not mistaken. And I don't know, Dr. Green, if that's the one you were thinking about specifically, or if you're thinking about a different vaccine. Okay, because I feel like, yeah, I know it was initially passed in like Tennessee, but I think it actually caught wind. So yeah, prescription contraceptions. And again, it's an opportunity to bring it up. I do or have and continue to have people younger than 14 on birth control for pregnancy prevention. And sorry, my dog is making a mess behind me, for pregnancy prevention. And, you know, most of the time, thankfully, there's a parent or a guardian that's coming in with them and is like, yep, got this. Sorry. Okay. Which of the options below does not require parental consent? Treatment or advice for over-the-counter contraceptives, diagnosis and or treatment for STIs, including HIV, pregnancy or prenatal care, counseling for substance abuse, E, all of the above.
All of the above.
Okay.
I would say D. I don't know.
Okay, we got 2 for all of the above and 1 for D. All right, let's see. E, all of the above. Parental consent is not required for any of these things. We now have an over-the-counter contraceptive in addition to emergency contraception. We said diagnosis and treatment for STIs, including HIV, can begin as young as 12. Pregnancy and prenatal care, right? So if you're pregnant or if you, the person, are pregnant, you can care for your baby, although your parents might still have to provide consent for you. And then counseling for substance use. Awesome. Questions about any of these things? All right. So the next little section in here is really just about cultural competence and respect. And if you haven't ever taken the Harvard implicit bias test for many things, definitely do it. But it's really about just being aware of your own implicit biases, including when you just like you're walking into the room and you might, especially because you guys go from different ages, right? So you might have like a little one in a room and then, you know, maybe someone that's geriatric population and then a teen, you know, so just kind of being able to readjust your thoughts before you go into these rooms. Being open. One of the examples I use when I'm teaching my residents, particularly about sexual history taking, is, you know, when I was a resident, I had a young person come and I asked them, you know, like who they like, what are their sexual preferences, and their response is literally like, I'm pan-gray sexual. And I was like, okay, can you tell me what that means? Because and I was like, I haven't heard of that, so you can just share what that means. And they defined it for them. But you know, like it's just one of those things, like when you go into the adolescent room or the young adult room, just being like, oh, okay. Or however you do that with your face, you know, that's my face. So just being open to whatever they may tell you. And that was a long time ago. So that definitely caught me off guard. Be flexible with language. It's not uncommon for you to have a young person that maybe they identify maybe they are like a transgender woman, transgender guy, and they call their chest breast or their breast chest. And they have a different name for their menstrual cycle. Just be flexible with adjusting your language so that you're not re-traumatizing them over and over again. Likewise, it's one of the things I'll say, try to be not necessarily inflexible with, but just be cognizant of trying to help young people identify the proper terms for things. So it's one thing for me to have a different word that makes sense for a body part. It's another thing for me to call my penis at age 17 like a wee-wee. That's probably not appropriate. So just kind of find the balance there. Recognize that cultural, faith, and familial practices vary. And so, you know, I always share, I had a young lady come in, star student, trying to get some kind of tennis scholarship for college, and was like a devout Catholic person, and came in, and you know, I asked her if she was having sex. She's like, yeah, I'm having sex. And I was like, oh, okay, well, you know, what can we do to, you know, make sure that you're able to go to college on that tennis scholarship like you had planned? And she's like, oh no, I don't do birth control. You know, my religion says I don't do birth control, or, you know, and in my head, I'm also like, but your religion also doesn't really like you to do premarital sex, right? But that you don't say that. So like, it's really kind of, I'm like working with her with where she is. And I use that as an example because sometimes you get that dichotomy. You're like, you just told me this. What I know about whether it's a faith practice, a cultural practice, or whatever says this, they don't match up, but you just go with whatever the patient is letting you do. So we talked about other things as far as pregnancy prevention for her. and without telling her, like, it doesn't make sense that you don't believe in birth control, but you're not supposed to be having premarital sex. We didn't say that. Didn't say that. And then again, like I demonstrated with the pan-gray sexual patient, if you hear something that you're unfamiliar with, ask. Teens, they like a lot of the drugs. I used to be an expert on all the drugs, and now they say stuff, and I'm like, I caught like 4 of the words. Could you come back and like, what were the other ones? Educate me, please. So just be open as best as you can. And again, it's really challenging for y'all because y'all are going between ages and stuff. And so that's hard. As far as communication skills, these are all things that we were taught in medical school, but really, I would say the biggest thing is be you. As you can tell, this is kind of me in clinic anyway, is I'm pretty like funny, and I can be serious too, and I can be blunt, but like be you, so that whatever you're displaying is authentically you. And so, my nonverbal communication matches who I am, who they see me as, and it's still culturally appropriate. Really, you guys hopefully know how to balance open and closed-ended questions. But I would say, a couple of things that really get you farther, even with your sexual history taking, is if you ask this question before you get your sexual history, you can kind of lead all things sex and drugs back into it, which is, who do you want to be? What do you want to be in life? What do you want to do after school? A lot of my sexual history taking always ties back to, like, so you mentioned you wanted to be a nurse. Like, how do you feel like that's going to work if you are doing X, Y, and Z? Or you mentioned you want to be a graphic designer and have your own business. If you ask that question early enough while you're building rapport as far as what they want to be, that's a great way to tie things back. And you'll get a lot more open-ended responses and have to ask maybe a few less closed-ended questions. Obviously, there is need for closed-ended questions. Like, do you engage in transactional sex for like food? Like, do you engage in sex for food, housing, safety? Right? That's a specific question. Empathy. I don't think you guys are sociopaths. I've seen expressions change the entire time. And so just kind of be aware of that and do your best. Even when they say things, especially now, I feel like I finally feel old. I won't share my age, but I look probably a good decade younger than I am. Even, yeah. I'm not aging. It's kind of scary. But even I hear stuff and I'm like, I don't relate at all, but I have to be empathetic. And so, just keep doing that. And then again, clarify when you need to, you know, and then, they should tell you whether they understood you. If you feel like you said it well and they're like, you didn't say it well, it's okay. You might have, that might be how you say it to everybody else. With this patient, you have to find a different way to say it. And then I always give my patients or ask them for 3 areas to teach me what they learned. Like, what are 3 things that you learned? Or what's your one, if there's 1,000 things that we had to go through, what are the 2 things you're going to do when you go home? Keep them engaged. And then, introduce the conversation, be respectful. One thing you could always say is, so I talk about this with all of my teens, because hopefully you do. And so some of these questions may feel a little uncomfortable or maybe, a little embarrassing, but we're going to ask them. So, don't be afraid. It's okay. And again, remind them that it's confidential. And so the example on the screen is really, thank you for joining us today. I like to give all my young people an opportunity to talk to me alone so we can explore additional issues and empower them to talk to their doctors. And then you can, if you're not already at that section, you can let them know that it's coming. If you have really young adolescents, because I get this question often, like, so when I have an 11 or a 12-year-old, I'll say, mom, dad, patient, we always like to give each of you guys your alone time. So I do alone time with the parent too. We like to give each of you guys your alone time. For the kid, this might be a chance for them to ask some of the questions about how their body's changing that they might be a little embarrassed to ask. That kind of thing is a great way to phrase it. So don't be afraid. I don't know if you guys are or not, but just in case, don't be afraid. And then really normalize again the fact that this discussion has to occur, and get them used to it. When I have new patients, because I don't ever assume that they've, like, if I have a new patient at 16 and they're coming in with Guardian, I don't ever assume that they've had the ability to talk to their doctor one-on-one. So I'm always like, in this practice, just so you know, this is what's going to happen at some point. Hopefully we all have safe, welcoming, non-judgmental environments. And sometimes we do our best, but maybe it's a colleague or coworker, right? And so we have to do positive calling in about, hey, I noticed that you still call Bobby Sally, and Sally is their dead name. Like, how can I help you remember to call Bobby Bobby? Or, I noticed that you always talk. I'm gonna think of one of my patients. You always tell my patient Sally that her clothes are too short. We know her. We know she likes to have her midriff out. That's how she comes to clinic. Can we just let that be? She at least came to her visit. Those kind of things. And then again, mentioning mandated reporter obligations. And I would even go so far as when you come across something that you have to report, making sure that you actually let the patient and the parent, if there's a parent there, know, right? And so I'm like, thank you for sharing that. That's one of the things that we really are worried about and can be really concerning. And so because of that, I really do have to invite some other people in. We really need to make sure that you're safe and that we get this situation under control, or we find this person that did this to you, X, Y, and Z. And then I go tell the parent, like, hey, the same thing. And I'll give you an example. I actually had two patients. They were 15 and 14. They were girls. They were new. We won't get into this, but one of my residents likes to always ask, like, are you having sex? How old is your partner? And so I had to talk to her like, that's not, no, don't do that. There are other ways to kind of get at if the relationship's age appropriate before you ask an age. So anyway, she did that. And this is an example where the 15-year-old was dating someone who had just turned 18. Like, they had been dating for a long time, but we caught them in this visit as there was a birthday. The mom actually didn't know she was in a relationship, but the mom laughed. She was like, they'll teach her not to have sex. She didn't have a problem with the guy. She knew who the guy was. She just didn't know they were sexually active. But she didn't have a problem with the guy. But she took it well. The girl, the rapport was broken with the young lady, unfortunately. It came back eventually, but it took a minute. But, I let both of them know, like, unfortunately or fortunately, I know you guys have a nice, healthy relationship. You guys are in class together. You guys do blah, blah, blah together. But unfortunately in Alabama, you guys can't necessarily be having sex together because of the age, that kind of thing. Okay. And so here's another example. So this is an example of, just, I want to take a few minutes to talk about your overall sexual health, which is an important part of your overall health and something I talk to all my patients about, again, normalizing it. Before we get started, I want to make sure that everything's confidential. And that means it's private between you and I don't share it with your parents or caregivers unless you say it's okay, or I think there's a concern for your safety or someone else's safety. And then other healthcare people might need to know. I can't tell someone. Anybody say anything? No? Okay. But that's an example. So now we're going to talk about strengths-based approach. And this is the idea of really shifting the narrative. And I'll say, as a pediatrician, because I'm a pediatrician, so they teach us like sex is bad, which I'm not saying it's great, but sex is bad. Don't let the children have sex. Like, the world will collapse, right? That's pediatrics. Like, that's pediatrics 101, right? And so, we definitely in peds, but probably all of us in medicine have to shift, really thinking about how to talk about it in a strength-based way, in a more positive way, not because we want to encourage people to have sex, but by doing it in a positive way, we help them reframe their activities and they're actually able to make better judgments about what they're doing. We often use things like, you're at risk for da 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 da. We all do that because we're all trained to do that, right? We all went through some kind of medical school or nursing school or NP or PA school. I know you guys are not NPs or PAs, but we all do that. But like when we talk to the patient, that goes over deaf ears, and you'll hear more about that with Dr. Lopre when she talks about PrEP. So when we think about strengths-based, we really just want to make sure that they remember sexuality is a normal part of life. All of our teens are sexual beings, including some of our teens that are disabled or have disabilities. And so, don't forget about them as well. Like, maybe they're in a wheelchair but they're sexually active. Or my favorite is a set of twins who are very, very, they have a lot of different disabilities and are probably definitely not sexually active, even as now they're like older, but like they like to talk about sex. So I asked them so that they can at least ask their questions, and I try to answer them at their IQ levels, not super high. You want to convey that sexual feelings are natural. And so again, this is all based on the young person in front of you. So do I go to an 11-year-old like, hey, sex is a normal part of life? No, I don't do any of that. But so you want to take the person that's in front of you and kind of see what questions they may have and approach them in an age and culturally appropriate way. You want to listen to their viewpoints and things. And sometimes it's really just listening. My resident and I, we saw a patient and she came back and told me like, yeah, the patient wants to get pregnant. She was like maybe 18. She wants to get pregnant with her boyfriend, so on and so forth. And I went in and I was like, tell me a little bit about what's going on with you and your boyfriend. And I can't remember what she said because it's been a few years, but she had said something and it made me pause. And I was like, so tell me again who you're having sex with. And there was a third person in the relationship. And she's like, yeah, I'm in a throuple. And I think one of the Smith children, Pinkett Smith children made that famous or whatever. But she was in a throuple, and basically she was the youngest person, and they had decided that she was going to be the one to be pregnant for their little threesome. Yeah, these are real life patients for me. But but the point of the matter is, one, I listened, I caught that there's probably another person in the relationship, and then two, instead of being like, why are you in a throuple? Like, I approached it from, okay, so tell me, share with me what's going on in this relationship. What do you like about this relationship? Are there areas you can work on? That's a strength-based approach to this relationship. Obviously I would prefer her have one partner at a time, but that's not what she would like, so that's okay. You want to provide accurate information. Again, that goes back also to that, like trying to gently address young people that still don't know how to call their body parts the correct term. Not an inappropriate term, but the correct term. You want to make sure that you're addressing that. And then you want to reinforce their healthy decisions. So maybe the only thing they can do is they remember to use a condom like once a month, even though they're having sex every day. I'm glad that you are using a condom when you are using a condom, right? That's awesome. That shows that you really care about your health, that you care about the health of your partner. Is that probably true? We don't know, but because they're using it 1 out of 30 days, right? But it's the reality. So here's some examples of how you can kind of flip some things around. So case in point, you're only using condoms half of the time. That's a pretty big risk to take. You could get STIs, including HIV, and you could get someone pregnant. A nicer way and a more positive way to phrase that is, that's great that you're using condoms, right? That's like glass half full. Would you be comfortable with telling me about when you use them and when you don't? And then they can share that. And then you can be like, would you be okay if I share with you some strategies to help you remember to use it more often? Maybe that's a yes, maybe that's a no, I don't know. But that's a strengths positive way of approaching that conversation. Here's another one. Wow, that's a lot of partners for someone your age. When you are meeting a new partner, you always ask him about his HIV status, right? For someone like you, I would definitely recommend getting regularly tested for HIV, right? And probably most of us actually probably say that to a T, if we're honest. We probably all said that at least once, because it probably just kind of rolls off your brain. And you're not even thinking about how it sounds. A positive way of saying that would be, thanks for sharing. I really appreciate your honesty with me. When you're meeting a new partner, do you feel comfortable asking about their HIV status or about any STIs? I'd be happy to continue to discuss strategies with you in the future to figure out what works for you and what doesn't work for you. And so those are some ways of kind of flipping that language and making it more empowering. There's subtle things, or at least this one's more subtle than the first one, but they go a long way and they help to build confidence and empowerment in a young person. And my first PrEP patient, like they were like 15 and it was a lot of partners. And they were great. Their pediatrician loved them, but the pediatrician was like, PrEP is where I draw the line. I'm not prescribing PrEP for you. And so they found me, and literally like my face just had to be stone cold like normal, like the Stone Cold Steve Austin. That's the person, right? Yeah. Because I think he was like, yeah, I've had like 25 partners. I'm like, okay. And so you're interested in PrEP. That's awesome. You're taking charge of your life. You're trying to make sure you prevent HIV. That's literally how I approached it. Am I excited? Am I crying on the inside because he's had 25 partners at 15? I'm crying, yes. And for your information, he was not being trafficked or anything like that. He has a skill that put him in the entertainment industry very early in life, and so he has access to these people. So, all right. Yeah.
slide that you have here, you know, like, I think it's important. I always tell the residents, like, you know, you don't get procedures that you don't look for. And the same thing here is you're not going to identify opportunities for prep if you aren't having conversations like this, if you're not framing them this way, and you're not identifying people, you know, who are going to be at risk, right? So this is the like, this, it doesn't matter how good you are at providing prep. If you don't do this part right, you're never going to do it.
That's exactly, you need to be the advertisement. Madeline, that's on recording. He can be our advertisement for the program. Because that's exactly why, instead of just giving you like, hey, let's talk about prep, that's exactly why we give you this 2-part of like sexual history taking and then prep. Hit it on the head, Dr. Green. Perfect. And so now we're gonna do the 6 P's of sexual history taking. You guys are probably familiar with the CDC because they have 5 P's, but there are 6 P's. Madeline, remind me how long this video is, because I think I actually have time today. I think I'm doing good.
Yeah, I think we have it till 3:30, so 30 more minutes.
Okay, how long is this video?
Oh, that video is like 3 minutes, maybe.
Yes. Okay, we're gonna play the video. Oh, I gotta reshare my screen. Hold on. Because I gotta share this out. We're gonna play the video because usually I talk through them, but I want you to hear. Oh, I did it again. I want you to hear someone else's voice. I keep doing it. I need to share my screen. Sorry. Share sound. That might have messed up your recording, Madeline. Sorry. Okay. All right. Here we go. Let me know if you can't hear it.
It's important to talk about sexual health because that's how we all got here. It's a natural part of life, and by talking about it in the context of a regular patient visit, it normalizes talking about sex.
I definitely think sexual health in general is very stigmatized, where we don't talk about it openly.
Sexual health is an integral part of someone's general health and their well-being. So I'm not doing a thorough job if I don't ask those questions.
The 5 Ps that are traditionally used as part of a comprehensive sexual history are partners, practices, past sexually transmitted infections, prevention of pregnancy, and prevention of sexually transmitted infections.
Starting the conversation about sex with anyone, especially if it's a stranger or if it's a patient of yours that you've had for a long time, it can be really awkward. But I think the best way that I've approached it is with an open mind and non-judgmental kind of questioning. So I think my best advice is go at it with a genuine curiosity and wanting to, you know, really give them the best care.
It's gonna feel awkward initially, you know, it's a sensitive topic, but I think the more you practice, the more you incorporate that into your daily practice, it often becomes habit, and that's how habits develop. I think if we lead with care and love, oftentimes it's a little bit easier to talk about those things.
You've got to do your own homework to check your biases before you enter into the encounter. And you've got to be in a space where you are comfortable with yourself so that you don't have a visceral reaction in front of the patient that creates this uncomfortable dynamic that creates a space where they shut down and they don't give you that information.
Just having the brochures available and having the, you know, vibrators sitting on a counter, those things allowed patients to kind of bring up the conversation and say, I saw that what you have sitting out there, and it's, okay, great, let's talk about them, and here's the brochure, and these are all the choices we have, and let's send you home with something, you know? So when you get a response that a person is so happy that you brought it up because they have needs, that will reinforce you.
The National Coalition of Sexual Health and others have identified that these may not be comprehensive enough for all patient populations. And therefore, they've added a 6th P, which is being called plus. And within that are questions about pride, questions about problems with sexual functioning, and questions about pleasure. But I think, you know, it's important to talk about sexual health with your patients because we need to do it. And if we don't do it, who's going to do it? We need to normalize it.
Any questions or immediate thoughts from that video? I think the biggest take home is always the person that says, you know, as you do more of it and you practice more of it, it becomes a habit. And that's really what the key is. It's uncomfortable. It's uncomfortable for me sometimes. I'm like, ooh, you're really little. But, you know, it's habit. So I just go in and do it. So let's see. Okay. And so here are those 6 Ps again. I think the first 5 definitely people are familiar with. Number and gender of sex partners and concurrent partners and past partners. You can see the practices. And this is one area where I say you need to be comfortable with whatever language you're comfortable with. I will say, I'll say some people use traditional, vaginal, rectal, top, bottom, insertive, receptive. Whatever words come out of your mouth more naturally are the words you should use. Like, don't force yourself to say top and bottom if you're going to make like a weird face every time you say it. So just pick it. Oral. Don't forget oral. I forgot that one. Past STIs. And so, like, what have they had in the past? Protection. So how are they protecting themselves from STIs? This is PrEP. This is PEP. And we're not going into it for the purposes of this. DoxyPEP is now there too. So more things to add to your arsenal. And then, and these are all based on STI. So there's a whole, like the true 6 Ps have the contraception in it too, if you have a partner that's of reproductive potential. And then pregnancy, determine if the partner can be pregnant, can become pregnant. What's their pregnancy intention? Do they need contraception or emergency contraception? And then as they mentioned, there's a 6th one, which you'll see like 6 Ps, you'll see 8 Ps. But the idea is, are you talking about satisfaction during their sexual encounters? And that actually is still applicable to our younger people. Like, a lot of times I have teens that come in, it's like, you just came in like last week, I need to get STI tested again. Okay, let's sit down and have a talk, right? Clearly, you're concerned about something. How can we make these experiences more pleasurable for you? Since you're having sex, how can we make it more pleasurable? Because you're coming in every week, which is good. I want you to come get tested, but you have the same partner and you're coming in every week. Clearly there's some anxiety there, and that can't be satisfying. Functioning and concerns, I think, which we're all used to. The young person's like, I don't feel like I want to have sex anymore. It feels different, or those kind of things. And then understanding gender identity, sexual orientation, and making sure that we are aware of those things. Here, it's really just making sure that you remember that within all of these things, we had those stages of adolescence. And it's important to know the stages of adolescence so that you can ask questions appropriately. And we'll get to that as well. And so you can see some sample questions. And again, the CDC has a really good handout. So I won't read these to you for the sake of time and for the sake of your attention. But you can see all these questions. I like this because this is really what a teen sexual network looks like. This is it right here. Like, you think you're having sex with this person, and let's forget that you have all these partners, but this person has all these partners, right? That's what a teen sexual network looks like. But they only ask the partner about their immediate encounter. So some developmentally appropriate questions for, are you having sex and things like that. So if they're young, I'll start out with something like this, where, we talk about the friends that you hang out with, or any of them in a romantic relationship. Do you have someone that you have a crush on, or a boyfriend or girlfriend? What do y'all like to do? And I'll ask, do you guys hold hands? Like, if they're the teen that truly is not answering questions and you have to go to close-ended, are you guys holding hands? Do you guys like to kiss? Do you guys do other stuff? And I'll leave that open to see what they say. Don't be alarmed. Sometimes you have to define what sex is to this age group for the ones that are having something that you think is sex. So the 11-year-old that's like, no, I don't even like anybody. Don't do that to them. But for the maybe the 13 or 14-year-old that's like, we do some stuff, but the clothes are all on. And you're like, oh, okay, what does that mean? And there's one patient in particular, she's had an STI 3 times when she was in the early adolescence age before she really believed this, when we told her, like, these things are different ways that you can have sex. Someone had told her that sex looks a very specific way. And so she was doing other things. But because she had been told that originally, when everybody else was like, no, but that qualifies as sex, it didn't process for her. And so don't be alarmed if you have to explain that, or explain what a rectum is, that kind of thing. Middle adolescence. You could say, I want to make sure that you're overall well. So since sexual activity can impact your health, can you tell me if you've had any sexual relationships? And if so, what kinds? And then obviously for late adolescence, you can be even more direct. I have a colleague who, Dr. Titchen out of UCSD, who she's a human trafficker person. And she always even starts with, like, can you tell me about the first time you've had consensual sex? Recognizing that many of our young people their mind may jump to their first sexual encounter, which may not have been consensual, and they've already handled that, they've addressed it, they've been in therapy for it or whatnot. But like, you ask how old were you when you had sex, and they go automatically to that first non-consensual encounter. And so there's a balance with that, but just kind of being aware of that, finding some kind of way to document in the chart that maybe someone has had a non-consensual encounter. It's been reported, it's been documented, they're in therapy, they're in treatment. Please try to ask your questions so as not to re-jog this person's mind about that. For 2, which is practices, and this is it too. Have you ever had sex with someone? By sex, I mean vaginal, oral, anal, traditional, regular. I hear those terms. And I've actually heard regular too for penis and rectum. So, just clarify. And you could say, no, they've never had sex, or they've not been sexually active in the last year. Like, okay, awesome. So, what are some ways that you keep yourself healthy? What are some of the things that you do? Or like, if they've had sex, you can ask about, how many partners they've had recently. Remember, it is important to know recently versus lifetime. Like, a 20-year-old that's had 20 lifetime partners, not awesome, but I'm like not freaking out. A 20-year-old that's had 20 partners in the last 3 months, I'm freaking out, right? Different thought processes are going through my head. So just kind of make sure that you're able to distinguish those. And again, you can see types of protection, types of sex, genders, and then consensual or not consensual sex. And then one thing, that comes up a lot, I do research, I should disclose that as well as clinical care. And one thing that comes up a lot are there are teens that are like, yeah, I've realized that every time I get tested, like I'm thinking getting all the tests, but I'm getting the chlamydia and gonorrhea tests. And I thought I was getting an HIV test. And so you don't have to be extra technical, but you can be like, this is how I do it. Let me just say it like that. I ask, where are you having sex? And I tell them, so we're going to test you in all the places that you're having sex. And then I specifically say, when we use your urine or your mouth swab, we're testing for X. I say whatever we're testing for, and then we're going to get some blood, and that's going to test for Y. And that can be helpful. Okay. And then past history. So you can see the questions here. Sometimes you do catch individuals, or find individuals is probably a better phrase, that have an STI and just haven't been treated, or have had an STI, been treated, but are still with their partner who has been untreated, right? And so, don't forget about that. You can do expedited partner therapy in Alabama as well. And then explore abstinence.
Because we've looked at expedited partner therapy before, and the law in Alabama is very strangely written. And it seems to like imply that the only people that can do expedited partner therapy are like, public health nurses or something like that. So am I wrong there, or is this Center for the Health Department?
It is strangely written. Do not do as I did when I was there, because it is strangely written. I don't know what it is about that law. It's strangely written here too, but not to that extreme. Didn't do it often, I'll say that, but like for the individuals where I was like, okay, this is like, I'm just gonna I need your name, the name, the thing. And I would actually even call the patient sometimes. That's how I ended up having to do it. Does that make sense? So I would call and I'd be like, hey, or I guess their partner would say, this is the doctor wants to speak to you. I'm like, hey, what's your date of birth? Can I send you some medicine? That's how I would do it. Because we were getting too many kids that, not a lot, but too many that were coming back in. And it's like, we keep treating you. You're like, I know, Dr. Hill, I'm taking my medicine. I'm like, you're still with so-and-so? Yes. I'm like, so that's one way that you could probably do it, because then I guess, I don't know if that's true. Obviously you didn't test the person, but
you talk to them on the phone. Yeah.
That might be one way. The other thing I do, I started, for some of them, I started also encouraging their partners to come, or when their partners did come. Like it's never, my staff hated me because whenever they're like, oh yeah, my boyfriend, my girlfriend, whoever's out in the lobby, I'm like, oh, and they're sexually active. I'm like, oh, you think they want to get tested today? I don't know, Dr. Hill. Okay. And I would just walk out there and be like, hey, since you're here, is it okay if we test you? And granted, when they're younger, like if they're under 19, they still have Medicaid. And then some of them actually had their whatever their insurance of choice was if they were older on them. And I was like, get them registered. Let's do their STI testing, and keep it going. That was the other thing I did to try to get around the weird partner expedited therapy law. But it is legal, but it is weird. Yeah, I don't know if that's helpful or not, or that might be an ask your attending thing. Don't have your attendings come find me. You want to explore, abstinence, number of sex partners, condoms, STI, all that kind of stuff. For the individuals that are abstinent, I'm always like, what keeps you motivated to stay abstinent, or like I also say, if something changes, because I don't want them to be like, oh my gosh, she's gonna be disappointed in me if I have sex. If something changes, please come and ask me questions. Please come, if you have them, and ask me questions. I don't know if you guys do condom demos if and when they're needed. But doing a condom demonstration when you need to. I had a patient, we used to cover the detention center, and they got out of the detention center. They'd been out for a while, and they like walked into our clinic. One of the nurses came and got me, and I was like, oh, I know you. They're like, yeah, I was at, so-and-so detention center. It was so cute, actually. They have a new relationship, and basically they had asked me if I could show them how to use a condom. I just walked about the street. I don't know. I get weird things. I'm not the best person to compare. I get weird things that come into my purview. I mean, he was like a young adult person as well. So like I was like, yeah, come on back. We'll show you how to use it. Don't be afraid to do that. Making sure that they're using, if you don't do the demo, making sure they're using it correctly, make sure that they know not to use an expired condom. I have had teens that have used sandwich bags as condoms. So like asking them if they're actually using a condom is real, and making sure they're not putting two condoms on each other, right? You would not believe how many teens don't know that. So just kind of being aware of that. For pregnancy, so again, this is about sexual history taking, and so pregnancy is another STI, it's another STD, whatever you want to call it. It is sexually associated and acquired. And so can you prevent a pregnancy? Can you do spacing between pregnancies when they're young? All those kind of things. Are they able, or do they feel like they're even able to consent and tell their partner no? And do we need to do something different? Like, are they being trafficked or something? And then do they need emergency contraception? That's probably what we're all weakest on, right? Is emergency contraception, remembering it. And then the 6P, sexual satisfaction and all the fun things, as well as supporting for a young person's gender identity orientation. I'll tell you, all the organizations, so that's AAFP, AAP, ACOG, the Society for Adolescent Health and Medicine, all recommend, like regardless of, like, I know there's gender affirming laws as far as medications, but regardless of that, like they all recommend being affirming of someone regardless of their gender. So just kind of be aware of that. And that's where that bias comes in, because it may truly be something that's different than your personal values, but just kind of figuring out how to balance that with you and your doctor role. You really want to make sure that you're covering the puberty and sex part, particularly for the younger and middle adolescents, so that they know how puberty goes and what to expect, gender identity, sexual orientation, and attraction and sexual activity. And so you can see an example right there. And then I love the question for the younger child. The younger child could be, do you have any questions about your body? You don't have to talk about sex. Do you have any questions for your body? And go from there. And sometimes, I'll be honest, like, I've had grandparents come up to me like, hey, I know we're finished with the visit, but can you go back in, because I forgot to tell you little Johnny, who's 13, is going to his first party. Can you go have that talk with him? I'm like, oh, great. That's a great time to have the talk. The visit's over, but that's okay. So like having that one-on-one time may remind your caregiver or guardian of conversations that they know they should be having, but are too uncomfortable to have. And then you can see what they're saying there. That's a little child in that picture. Okay. And then looking at sexual satisfaction, as well as gender identity. Still, again, this is some tips that you can do in order or you can do when you have an individual whose sex assigned at birth or natal sex may not be concordant with their the sex that they identify with or the gender they identify with. Or their partners may be different, right? You can validate their feelings, gain an understanding, try to make sure that they're not experiencing any dysphoria or doing any harm or being taken advantage of. Encourage them about, how to have a safe and healthy relationship, and know the resources in your area, right? So, who provides care, like whether it's gender affirming care, whether it's medical or mental health services, and what organizations are available. And you guys are I know you're in Gadsden, but like you're close enough to the metro area for all these things too. And then, again, questions. I like the question of who do you find yourself attracted to, and just leaving it there. I'm still like old enough to where I have the habit of like, do you like guys, girls, or other? And then I'm like, but there are people that don't identify as guy or girls. How do I phrase that? So this is a great way to phrase that. Who do you find yourself attracted to? How do you describe your sexual orientation? So these are some things to think about. And again, it's really about knowing your resources and making yourself feel more comfortable asking the questions and fixing your face in case your face is always like, oh. So do's and don'ts, always assure confidentiality, explain why you're asking the questions you're asking the patient to describe what they do specifically, and then really try to make sure that you're assessing their comfort with the behaviors that they're engaging in, or do you need to increase their knowledge and gap? I usually say this, but I forgot, sometimes they're getting it from their parent, meaning the sexual health information they're getting from their parent, and sometimes you have to correct the parent too. So like gently bring the parent back and be like, hey, so we were talking about da 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 da. I thought we should and not talk about like whatever the child is doing, but like I just wanted to, clarify how this is transmitted or something like that. So don't do gender-based pronouns when you're referring to sexual partners. Use judgmental language or use slang unless the patient offers first. And I will say too, be prepared. This is the flexible part, because maybe the patient does have a different name and pronouns. And, some patients will be like, yeah, my parent never gets it right, but it's okay. You need to still call me by my preferred stuff. Other patients will say, don't even try to do it while the parent is in here. But when I'm alone, you need to call me by my preferred things. And so just kind of be aware of that. These youth know the living situation they're in. And sometimes you can be more detrimental by trying to force the issue when they've already told you, like, don't bring up that I like Bobby, or Bobby's my name, or that my preferred partners are male or female or whatever. And then I will say too, likewise, there are parents, and I've had several that it's just really hard for them to wrap their head around the new name and pronouns, but are actually speaking, and they're just so used to calling Bobby Sally that they're not meaning any harm by it. And so Bobby's like, yeah, I know, they're gonna call me Sally. It's annoying. So we're going to conclude with listening to some youth, because it's really important, since we're talking about young people, to be able to listen to their voices. You have heard mine long enough. And I'm going to hope that the sound is playing. So here we go.
Like for me, I remember one of the first times I talked to my mom about birth control was I had like, I don't know, I had gotten caught doing something like bad. I don't remember what it was. It was like, maybe I like snuck out or something. I don't remember what it was. But and I remember she was like really disappointed in me, and she was angry, and she like said like, oh, now do we need to put you on birth control too? And like that's something that like sticks with me, like has stuck with me since she said that. Like our relationship has come a long way from that. Like I was able to like, I have like the birth control implant, and like now we have a more open conversation between us about it. But that was my first kind of conversation with her about birth control, and that really like made every conversation uncomfortable from that point on. And then with providers, I think it's similar to like I felt like I had to, like when they're like, are you sexually active? It's like, yeah. And they're like, okay, how many partners do you think you've had? And I always feel the need to like really like lower it than what it actually is, just because based on the way that they talk about it and the way they're obviously uncomfortable, just makes me uncomfortable,
Any thoughts about this young lady, portrayed by the young lady on the steps, said?
Yeah, it's I don't know, whenever I think about this, like I have two daughters who are very young. And so this isn't a problem yet, but eventually it will be. And, um, I think, as a parent, like you always want to have you want to think that you've got an open relationship with your child and that they would approach you with anything. And so I think that when I hear stuff like that, and obviously you don't know what the situation is for this individual and their relationship with their parent, but you feel like that potentially the relationship is actually already broken down before we got to this situation. Um, that the kid is saying, oh yeah, well, they were disappointed in me and therefore I felt like the relationship is broken. Well, you were running out and doing things that were potentially unsafe, and weren't communicating that with your parent. So I think that the relationship started broken and was something that had to be fixed in this situation. I think the other thing is that it makes me think about is the before I lose my thought here. Just thinking about where people are getting their information. So you mentioned that like kids might be getting information from their parents, which may be correct, but where's the main source that kids get information from is other kids, right? And TikTok. And I don't look at TikTok. I don't know, what's on TikTok right now. There's a million different things on TikTok, but I guarantee you that they're getting their information on TikTok, and that the kids are getting bad information, because if TikTok is anything like the rest of the information and social media and the internet, it's all, most of it's wrong. So that we're really looking at a kid who's been getting potentially incorrect information about sex and risks and what's okay, maybe being told that they shouldn't communicate with their parents, who even knows. And so it's like we're, as physicians, having to try to help a child navigate through this environment where potentially some things they've been told are right, potentially many things they've been told are wrong. And we have to kind of untangle that, and then also try to figure out, like, just because they think that they can't confide in their parents, that doesn't actually mean that it's true. I just had was it 15 or 16-year-old patient of mine, found out she was pregnant, and initially it was like, okay, make sure you don't tell her parent, it has to be absolute super secrecy. And then the like 2 weeks later, her mom's coming in to see me, and her daughter's there with her, and they're like, oh, by the way, she's been having this symptom come on, happen during her pregnancy. What do we do about it? And so I was able to just be like, oh yeah, so this is the things we look for, so it's that apparently in the interim had opened up and become become open and no longer a secret. So anyways, that's just my kind of like thoughts on the whole thing.
No, I appreciate that. I appreciate that. And I think what you're getting at is communication is key. With like, that would be the big takeaway. Communication is key, and there's a scale, like there's a gradient. That's the word I want, a gradient of everything. Like, and the first thing I think about is, and I usually say this particularly when I teach on STIs, is access to comprehensive, medically accurate reproductive or sexual history is, everybody doesn't have access to it. And so like you said, like some people are trying to find access through parents or through peers or through social media. And so like, who's communicating to our young people about that, which is exactly what you said. The other thing, and I agree with you, because I was, as soon as you started, I was thinking, I was like, it is on a gradient. And full disclosure, I also am an HIV provider for teens. So like one of the clinics at Birmingham, I was a provider, and I'm one here in Atlanta too. But you would be surprised, just like you said, you'd be surprised, just like you're a 15-year-old that was pregnant. There are some parents where, like, I'm like, how do we probably need to let one of your, like, somebody, you need to have a support person. We should probably let someone know, and they're like, I mean, ideally my parent, but I don't know how they're going to take it, and tell their parent. And obviously the parent is not happy or upset or frustrated or whatever. But then you see this like, okay, Like, let's go. Like, what we got to do? I do see parents take it wrong too, take it pretty badly, but I do see a lot of parents, regardless of whether it's pregnancy, it's an STI, it's a suicide attempt, HIV diagnosis. You're correct. You're completely correct. Some parents actually do take it better and take it better than we think. And I think that's why it's always an opportunity whenever it's one of those things like, hey, so this could pop up on your explanation of benefits or whatnot. One of the options I always give is like, do you want me to talk with your parents with you? Do you want me to bring it up with you? So I think you hit the nail on the head with that. I should also mention all these voices you hear are from one of our studies. And they're 14 to 24-year-old young women in Alabama, if I'm recalling correctly. Okay, any other thoughts or comments? Spencer and Fernanda are like, we just trying to make it to the end. Okay, last video, I think. Maybe not. So these are videos that you have access to because I think Madeline will give you the slides. And these have a bunch of different video scenarios for you guys to practice or not practice, but to look at and see if there are things that you want to incorporate or to be like, you know what, I know that this was meant to be a good video, but I can do that even better. And so make use of those. So we're not going to do that, but I will play this. This is one of our last slides. Let me play this for you.
As a young woman, like today, like right now, it's like there's already so many, like we get so many different like judgmental messages about sex, whether it's slut shaming or like you're a prude. And it's important that your doctor's office is a safe space where you don't have to worry about like any of those preconceived notions that you're fed all the time, and just a space where you can, it's a space where you're supposed to learn and like be able to talk about the things that you're going through.
One more thing, I will also say a lot of us don't know about the topic of sex positivity, and we don't know that such a campaign is existing and people are we don't know. So the stigmas around it, like we're trained to believe them too. And so that might make us more uncomfortable as well. Mm-hmm. And so I don't know how I'm trying to word this, y'all. We're trained to believe the stigmas too. And when it comes to sex positivity, even though we might not know about it, we want to have the conversation and we want to engage in that type of dialogue with you as a healthcare provider. As the healthcare provider, it's your job to set the tone and create the space for us to have the conversation about sex positivity, because we're all learning. There. Ooh, yeah. Look, at this point, I stopped thinking for myself.
Okay, so those two young ladies are giving us our mission of going forward and creating spaces and that are safe for them to learn in and grow in. And so hopefully that's what she'll take from this. I'm gonna show you the slide. This is our team. There's some more Prep Pro information on that QR code right there. But I'll stop and see if you guys have any questions. Yeah, any questions for us, myself or Madeline? Usually there's a question for Madeline.
Madeline, do we have access to the website resources now?
Yeah, so I will send you guys an email follow-up that's going to have like a resource sheet with a lot of QR codes and links on it. And I will also be mailing the materials tomorrow when I go into the office.
Because I went and messed around on the website a little bit, and it looked like some of it required a login because it's like hosted on Google Drive or something like that. So I just wanted to check.
Okay, so if there's any problems accessing something you need, just shoot me an email and I'll make sure that you can access it. I went through and tried to make sure everything was accessible publicly, but if there's any issues, just let me know.
Very good.
Title 10 clinic that came up, and we didn't really talk about it. I Googled and saw that there is a Title 10 clinic near us, probably just 2 minutes down the road. Basically, the health department has its own clinic. So what does that mean for our patients? How can we use it?
Thank you. So Title 10 clinics are federally funded clinics, and they're protected by Title 10. So anybody going there can get confidential services. There's a list of services. Madeline, is it okay if I pull up a non-approved Prep Pro slide?
Yeah, of course. And we do have on some of the badge buddies, there's links to Title 10 clinic locators as well.
So since you guys found I'll show you a slide that I think has a list of all the services. The one thing I'll tell you is that you just need to check with the Title 10 clinic that you're looking at to see which services it provides. But they provide them confidentially and with sliding scale. Here it is. And so it can be nice for your patients that either, are coming in and are really, really concerned about confidentiality. Oh, let me not mess up the slides. That are really concerned about confidentiality. These might be what you want to do. And it looks like you probably went to this website down here. And so you can see all the different services that they can provide. Some of them provide prep as well. And so you just want to check with the one that's, especially since you have one near you, to see what they provide. A lot of them are located in health departments. Some of them are located right next to like hospital systems, like as an outpatient clinic or like an inpatient. I don't know if it's inpatient is the right word, but a clinic located in a hospital. But yes, it's a great place. And the thing here is that the federal law actually supersedes whatever your state legislation is. And so let's say that at some point pregnancy testing is not allowed unless you have parental consent. Then you could send them to a Title 10 clinic because that's not going to be the federal, that's probably something the federal government won't change, although I should knock on wood because you never know. But that's kind of an example. Does that help, Dr. Green?
Yeah, I think, just thinking of, when I looked on their website, they list services offered, birth control, shot, pill, patch, ring, cervical condoms, hormonal implants, diaphragms, emergency contraception, IUDs, sterilization. I don't know how they do male and female sterilization because they're not a surgery clinic. But they got this like list of stuff, and then women's, men's health issues and stuff. So like, I mean, previously I've been to other health departments, and vaccinations and stuff have been free. Is that typical with these clinics, that vaccinations are free, and then other things may have varying pricing?
It is, and it would be sliding scale. I will say, my memory from being in Alabama for the last 7 years, the prep is probably one of the hardest things. There are I don't know how many health departments there are, but if the Title 10 clinics in the health department, there's only like 1 or 2 health departments in Alabama, at least from my recollection, that do prep. They're trying to expand that, so just kind of be aware of that specifically.
Since you mentioned you're an HIV provider too, do Ryan White clinics provide any prep?
Yeah, so that is a great question. That is on the mind of all of our providers. So
like 100 feet from the hospital.
Yeah, the issue is, so Ryan White, it pays for everything. If you have HIV, you get dental care, you get everything you can think of. Maybe some of the more expensive brand names of something, maybe not, but like you get just about everything. But right now, the federal government currently has Ryan White written for the only HIV prevention is like condom and education. And so that's something we've been arguing, we being like Ryan White providers have been arguing for a long time, because it's like, if you have someone coming in and let's say they bring their partner in who doesn't have HIV and they want prep, you may or may not have a prep services that you're able to do. Like 1917, you guys are kind of familiar with at UAB, is like a big HIV clinic run by infectious disease. And they have a prep clinic, but it's funded slightly differently, even though it's within the building that houses all their HIV services. For me, when I was in Alabama, I worked in the adolescent health center. And so I would see my patients, that had HIV through Ryan White services. And if their partner came in, I literally would run to our billing person and be like, hey, I need you to print out like a billing sheet for this patient that doesn't have HIV on the regular billing so that I can do their prep work, and then that kind of thing. Dr. Lopre will get into the specifics of how to do all of that. But right now, Ryan White clinics, the way some of them are able to do prep is through something called 340B funding, which is this kind of discount funding based on like HIV medicines you do prescribe. You get some money back, some rebates and stuff back that you can use for something else. But there's not something specifically written in Ryan White that says you can also do prep, which is the challenging part, because it's just like, great, let's do that. That's a great question. Any other questions? Hopefully my anecdotes and rambling were useful. But the real thing is, have fun. That's what I tell everybody. Have fun with your patients. Working with adolescents is a great way to learn what you don't know and to feel old, and make you relive, your younger days. So I wish you all the best. And that's it for right now.
Thank you very much. Appreciate it.
You're welcome.
Yeah, thank you so much. Really enjoyed it.
You're welcome. Bye, you all.
All right, I'll be in touch. Thanks.